Hello and welcome. In this video, I will be talking about concepts relevant for effective mental health care in diverse societies. Imagine the following scenario. A 20-year-old female university student is referred to a mental health professional by her primary doctor. The student says that for over a month, her academic performance has been deteriorating, she keeps to herself, and she has not been eating or sleeping well. She says that she just needs some medication to be able to sleep, and this will take care of the problem. She also mentions that her mother performed a religious ceremony at home to help her focus better in her studies. What would be a helpful response from the mental health professional? Should the professional say that this is not a bodily problem, it is mental illness? Should the professional say that religious ceremonies will do nothing to help? When distressed, there are different ways in which people may understand what is going on with them. The student may consider this condition to be a problem resulting from something wrong with her body that is causing lack of sleep and poor appetite, which then is leading to poor academic performance. She may consider this condition to be caused by a human, demonic, or divine figure, for example, black magic, or poor alignment of stars. She may also consider this to be a result of difficult life circumstances or personal weakness. Or she may understand this condition as depression. The way in which one understands the problem also influences from whom and what type of help one seeks. She may prefer to seek help from a general medical practitioner or from religious figures or astrologers. A mental health professional may understand this problem through the biomedical model and may not agree with alternative explanations. However, it is critical that we explore and understand how the person seeking help and others in their life conceptualize the problem and use this understanding in guiding treatment decisions. Cultural competence and evidence-based practice are considered cornerstones of effective mental health care, and integrating them has been recommended as an optimal approach to improving the well-being of those with health difficulties. Mental health professions such as clinical and counseling psychology, psychiatry, and social work originated and developed in Europe and North America and were later brought to the rest of the world. Traditionally, these professions assumed that human functioning was universal. What this meant for mental health disorders was that they were thought to show similarities in their onset, symptomatology, course, and prognosis, regardless of where a person was in the world. More recently, a movement within each of these disciplines has emerged that challenges the universalist viewpoint and argues for culturally sensitive care. Research in cultural and medical anthropology, cultural clinical psychology, and social and cultural psychiatry has shown that how we make sense of our experiences, our emotions, our thoughts, our behaviors, both typical and atypical, differ across cultural groups. Differences in beliefs, feelings, behaviors, expectations, and social practices found across cultures have significant impact on corresponding subjective experience of psychiatric disorders and how they develop and change over time. In other words, the way in which we understand our distress, the way in which we express or respond to distress, from whom we seek help, and what type of help we prefer to seek also differs across cultural worlds. There are many definitions of culture, and there are debates about how to best define culture. Here is the definition that the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, uses. Culture refers to systems of knowledge, concepts, rules, and practices that are learned and transmitted across generations. Culture includes language, religion and spirituality, family structures, life cycle stages, ceremonial rituals and customs, as well as moral and legal systems. Cultures are open, dynamic systems that undergo continuous change over time. In the contemporary world, most individuals and groups are exposed to multiple cultures, which they use to fashion their own identities and make sense of experience. In addition to the characteristics mentioned above, age and cohort group, gender identity, race and ethnicity, sexual orientation, and socioeconomic status are also important aspects of culture. In a country like India that is linguistically, culturally, economically, and religiously diverse, mental health training cannot ignore the local cultural and community context of the individual. For example, we know that 68% of India's population resides in rural areas, and approximately 32% live below the poverty line. There is tremendous diversity in religious affiliation and practices, food habits, family structures, social expectations, economic and educational resources, as well as conceptual variability in the more than 20 primary languages spoken. The mental health needs of a 30-year-old farmer in a village in Karnataka, a 30-year-old software engineer in Bangalore, or a 30-year-old homemaker in Mysore will be very different from one another. And the treatments also need to be adapted for these differing needs. The relevance of attending to diverse mental health needs and preferences is certainly not unique to India. Many countries in Asia, Europe, and North America are becoming ethnically, linguistically, and religiously diverse. For example, in the United States, an estimated 13% of the population is born in a country other than USA. 20% of the population speaks a language other than English at home, and it is projected that in decades to come, racial and ethnic minorities will become the majority. Statistics that clearly highlight the need for culturally competent care. At the broadest level, culturally competent care has been defined as a system that recognizes and appreciates the importance of clients' local cultural worlds and adapts care to meet culturally unique needs at all levels of service. It is, as one researcher wrote, the ability of systems to provide care to patients with diverse values, beliefs, and behaviors, including tailoring delivery to meet patients' social, cultural, and linguistic needs. There are three core components of cultural competence: awareness, knowledge, and skills. These include awareness of the influence of one's own cultural identities, including age, gender, social class, sexual orientation, race and ethnicity, etc., on one's personal values and assumptions. Knowledge of how theories and methods of inquiry in mental health are historically and culturally embedded. Knowledge of sociopolitical influences such as poverty and marginalization on different groups. Knowledge of family structures, gender roles, values and beliefs, idioms of distress, help-seeking behavior of individuals one is likely to encounter professionally. Ability to seek relevant information from the client. Ability to select and modify as needed assessment and diagnostic tools, and qualify conclusions. And finally, the ability to select, implement, and adapt treatments to meet the client's unique needs. Now, let's talk about the second cornerstone of effective mental health care: evidence-based practice. The term evidence-based mental health, derived from the larger movement in medicine and public health, refers to the notion that provision of healthcare services should be grounded in evidence generated through scientific research. Within the field of clinical psychology, evidence-based practice is the integration of the best available research with clinical expertise in the context of client characteristics, culture, and preferences. The analogy most commonly used to describe it is that of the three-legged stool, where the three legs are best available research evidence, clinical expertise, and the client's values, needs, and preferences. This third leg of evidence-based practice includes individuals' socio-cultural worlds. It is important to note that what constitutes evidence for clinical practice must be based on empirical research within the particular cultural setting, and thus, evidence generated in Western countries may not be applicable to those living elsewhere, including in India. For example, it would be problematic to assume that psychosocial interventions such as cognitive behavioral therapy or interpersonal therapy that have been developed in Western cultures and have been shown to be effective in treating a number of mental health difficulties in those cultures will also be effective in other parts of the world. cultural adaptations may be needed before these treatments can be meaningfully used, and much research is needed to examine their effectiveness outside of the Western context. While research is taking place to generate evidence, it is important that mental health practitioners continue to be attentive to the sociocultural backgrounds of their clients. To summarize, cultural competence is the ability of systems to provide care to clients with diverse beliefs, values, and behaviors. Evidence-based practice is the integration of the best available research with clinical expertise in the context of client characteristics, culture, and preferences. A culturally competent clinician whose practice is evidence-based engages in the following: demonstrates awareness of his or her own sociocultural identities and those of the client, and works to explore how they impact the therapeutic relationship and treatment progress. Explores how the client and others in his or her life understand the problem and its causes. Explores what kind of help the client has previously sought for the problem and how helpful it was. Researches relevant scholarly literature to aid in the understanding of the client's problem. Uses scholarly literature and information gathered from the client to guide treatment. Evaluates treatment progress on an ongoing basis and makes modifications based on the information gathered. Thank you for watching this video. I hope you found it helpful.